All right, good evening, everyone, and welcome to Silver Cross. I am Deb Robbins, Director of Marketing and Communications. We're thrilled to have an absolute full room, and we're even more thrilled to have Dr. Tim Keating here with us, noted, exceptionally trained orthopedic surgeon. We're trying something new this evening because when we marketed Dr. Keating's program, it filled up literally in a day. And people were reaching out to us like, how can I attend? So Dr. Keating came up with the excellent idea to offer it virtually as well. So there are some people on Teams that are watching, and then we're recording the presentation so that afterwards, if you feel like you missed anything, you can go to the event on our website and you'll find the recording as well. So anyway, if there are any hiccups along the way, I apologize for that. We're going to try to address those. We have an expert from our IT team here as well. So now back to Dr. Keating. He is a fellowship-trained orthopedic surgeon at Illinois Bone and Joint Institute, the largest orthopedic practice in Illinois. He also runs an incredible website, keatingmd.com. And if you haven't looked at it, I highly encourage you to check it out. It's got some great resources and information. Dr. Keating specializes in minimally invasive hip and knee replacement. He's originally from North Carolina. He attended Davidson College, where he studied biology and competed as an NCAA Division I swimmer. Yeah, right? I know, that's pretty cool. He earned his MD from the Medical College of Virginia in Richmond, where he was inducted into the esteemed Alpha Omega Medical Honor Society. He completed a 5-year orthopedics residency at Rush University Medical Center, which we all know is recognized as an absolute orthopedics powerhouse in the United States. Following his residency, he completed a fellowship in minimally invasive and complex hip and knee replacement with the Partners of Midwest Orthopedics at Rush. He's dedicated to relieving pain and restoring function for his patients. He collaborates with each patient to develop personalized treatment plans and uses a combination of operative and non-operative approaches to help them return to their favorite activities. He and his team at his office emphasize and prioritize excellent patient care, focusing on accessibility and customer service. And one other thing that Dr. Keating is going to be talking about tonight is the concierge approach to medicine, which who doesn't love that? That sounds amazing. So in addition to his clinical practice, he has a keen interest in medical device innovation. He's working to advance surgical instruments and technologies to make procedures more precise and less invasive, which is a good thing for all of us. Outside of work, he enjoys spending time with his wife and their growing family. So now I'll turn it over to Dr. Tim Keating.
Thank you. Thank you so much. That was pretty much my whole talk. You did the hard work anyway. I'll just skip the part about me. Thank you guys so much for coming. I think this is awesome. Thank you to Silver Cross. I spend a ton of time here, and I love coming here. And it looks like you guys do too. So that's awesome. Hip and knee pain is a huge problem. I think this class booking out in 24 hours is a huge testament to that. That really affects your life, and you're doing the things you want to do. Nobody really wants to make that jump to surgery, but when you have to, there's a lot of ways to make it as painless and as easy as possible. So that's what tonight's about. My goals for this evening, get to know me a little bit. The introduction was very thorough. I'll go through that really fast. I would love for you to understand just the basics of hip and knee replacement, a little bit about how we do it less invasively, and then how we take care of patients. And then even if all that other stuff isn't for you, I do want to give you some tips on choosing a surgeon kind of from a surgeon's perspective and the things that I think are really, really, really important for being a happy patient. So I'm Tim Keating. I'm initially from North Carolina, born and raised. A lot of it is underwater right now, but still beautiful nonetheless. As many of you may or may not know, this is the furniture capital of the world. So my dad's a carpenter, my grandfather's a carpenter, and I kind of just assumed that that's what I would do for a while. So most of my growing up was spent doing woodworking, and I want to show you a little bit about that because it becomes relevant later on. So this is a piece of what we call veneer. It's like a really, really thin piece of wood. So basically you cut that up into a bunch of pieces like this, put it back together, and then make it into something functional. So that was my passion for a very, very long time growing up. And my poor parents had their tiny house in North Carolina. It's half filled with this Victorian era furniture that I built, and the other half is IKEA, and there's really no in between. And you know, it gets worse. Here's their dining room table. That's about 1,200 pieces of inlay. So imagine the anxiety of eating, you know, red pasta sauce on this table. That's what they have to endure every night. So I wanted to stay close to home for college. I went to Davidson, which is a small liberal arts college close to where I grew up in Chapel Hill. So I did get the opportunity to swim there. I was basically a Division I doggy paddler. After walking onto the team, I didn't have a ton of formal swimming before that, but I was tall and lanky, so they let me swim. But this is where I really got exposed to medicine for the first time. And then through a shadowing program, I watched an orthopedic surgeon do a joint replacement. I was like, this is what I'm supposed to do. That makes so much more sense. So from then on, that was my new obsession. I kind of transitioned to understanding and kind of loving everything about hip and knee replacement. I went up to Richmond in Virginia to the Medical College of Virginia for 4 years after that, and got more and more experience in orthopedics and loved it more, and then ended up matching at Rush for residency. There's 5 spots every year. There's about 900 applications for those 5 spots, and I was lucky enough to match with one of my best friends from med school. So him and I were 2 of the 5 for those 5 years. And that was great because I was terrified of downtown Chicago before I moved up there, and lived there for 6 years. Now I'm way more scared of downtown than I was before I moved up here. So happy to be on the suburbs. But as you know, Rush has some orthopedic giants, so it was a real privilege, you know, to have them as mentors and friends, and to kind of take different things from each one of their practices to build my own practice. So that's been really great, and I keep in really good touch with those guys and work with them on projects still, which is really nice. And now we're here at beautiful Silver Cross. I always think, you know, I come down through 55 and I think it's like a Las Vegas hotel, you know, in the middle of the cornfield. So I'm here every week, a couple times a week. We have a clinic upstairs in Pavilion B, kind of right above where we are right now. And then I'm here at least once a week in the operating room. In my first 6 months, I was the busiest orthopedic surgeon in the whole hospital, and so that picked up pretty quick, which I think is partly attributed to what I'm talking about tonight. Like, everyone wants this rapid recovery joint replacement, so that's really helped our practice grow really, really fast. So last year we did almost 500 cases. The majority of them were at Silver Cross. So the basics of hip and knee replacement. What we want to do is we want to take the abnormal anatomy, you know, the arthritic joint, the joint where it's not working so well, you need a cane or a walker or a wheelchair because it's stiff and it doesn't move how you want it to move. We want to transform that by restoring the anatomy and restoring the mechanics of your joint. We do that through what's called arthroplasty. Arthro meaning joint, plasty meaning new, so it's literally a new joint. It's not exactly what you would think, you know, kind of chopping you off here and here and replacing the whole thing, but I'll show you what it looks like. For a knee, what you want your knee to look like is this picture over on the left side. We're looking at this healthy cartilage in the knee. That's that smooth gliding surface in the middle of the bones. When that wears away, you have what you've heard referred to as bone-on-bone arthritis, which is these bones start touching each other, and that is extremely painful. It's almost like 2 live wires rubbing against each other. The cartilage has no nerves whatsoever, but the bone has a ton of nerves. So as soon as you have that contact, that circuit's completed, and it's really, really painful. So I'm sure, you know, some or a lot of you in the room have experienced that, but it's really kind of an otherworldly pain to have that bone rub on each other. And basically what we do is we shave out all the bad stuff and resurface it. There's a couple different materials for that. The material that I use most commonly is a metal with a ceramic coating, and there's a couple different metals that go into it, but there's a bunch of different options out there. For hips, it's basically the same thing. Here's the ball and socket of your hip joint all the way on this side of the screen, and what we're looking for is this normal space. When you wear away all that cartilage, you get this bone on bone, and then the way that we resurface the hip is similar to the knee, but basically you get this new ball and socket. A lot of these components are designed to grow into your bone, and when that happens, it kind of becomes a part of you. We'd like to see hips last, you know, 30 or 40 years. The youngest patients that I've done it in, I've done 2 28-year-olds for for old injuries, and my hope is that we never have to go back and revise those with our current materials. Knees, it seems like they're lasting, closer to the 20-year mark. It's just a little bit more of a complex biomechanical situation. So, the materials have gotten a lot better even in the last couple of years, which is great. So we talk about, I make the joke in clinic a lot about having your tires changed. It's kind of like a knee replacement, but the basic principles for putting them in is pretty similar. You want them to be aligned. Aligned means, they go in straight in relation to the bones and in relation to how you walk, and that ensures that they wear in a normal pattern. So, straightening out the leg, correcting the leg length for hip problems, that ensures that the wear is minimized. And then you also have your balance. If the tire is unbalanced when you hit the highway, you're going to feel that reverberation and that kind of shifting back and forth. And the same is true for especially a knee replacement, where you want the ligaments, the tension of the ligaments to sort of match the bone, so you have a very stable feeling knee. I always ask people that have arthritis, does your knee feel unstable over gravel or grass or sand, things like that? When you wear away that cartilage, you have all that extra space in there, so the joints can kind of shift back and forth, and you really lose the confidence in your knee. So one of the goals of the replacement is to give you back that stability. There's a lot of ways to get there. Traditional instruments, kind of what we would call the old-fashioned. There's fancier, sort of newer technology like robotics and custom guides. All of those things are designed to focus mostly on the alignment. We can get a scan preoperatively, and then intraoperatively is kind of executing that plan. What I've come to like a little bit more after doing kind of hundreds of each one of those cases is sort of what we would consider the next generation of instruments, which is making millimeter adjustments to match the balance while also executing the alignment. And that's a little bit more of next generation instruments, so I'll show you a little bit. So the question is, we have our goals, but how do we facilitate a rapid recovery? Because that's, the technical part is kind of my part to worry about. What you guys are most worried about, and as you should, is kind of how are you going to bounce back for this? How fast are you going to be independent? How much pain are you going to have? I think those are the biggest fears of patients before. Number one, I think people are very afraid to depend on other people, because everyone, you're very independent before the surgery. You don't want somebody to have to take care of you after. I think that's the number one thing. I think people are also worried about pain. Those are the two biggest things. So if we can get you mobile right after, we can get you up walking the same day. If we can have your pain controlled with a variety of different medications, then it's a better experience with a rapid recovery. So to do that, we gotta do minimally invasive surgery. Basically, all minimally invasive surgery is knowing the anatomy and respecting that anatomy, so that you can go in, resurface the joint, and get out with the the minimal disturbance. So I'll go through it a little bit, but basically, if you do minimally invasive surgery with less tissue trauma, you're going to have less pain and swelling and inflammation, and you have a quicker recovery. The nice thing about having less pain is that you have to take less medicine. So our patients get about 30 pills of narcotic, and I probably only refill it about 10 or 15% of the time. So most people are able to get through it just with that many pills. That's a little bit different now than in the old days, where in the old days they would give you 100 pills of narcotics and you would go home and take them, and that's all you had. What we do now is what's called multimodal analgesia, and it's something that I helped develop when I was at Rush. But basically, you take a lot of different pain medicines that all work in different ways, which is an anti-inflammatory, some pain medicine, and I have patients that take no narcotics after surgery. It's more rare than just taking a little bit, but people still do it. And for some people, that's a goal going into it, is not to take any narcotics. When I graduated fellowship, I had a good understanding what I wanted to use. The problem was the instruments that I wanted to use to do minimally invasive surgery didn't exist. So I worked with a company to go back to the drawing board a little bit, and this is when I got to kind of go back to my woodworking roots. When I was designing furniture, I used to do a lot of computer modeling. So I was able to work with a company and kind of tell them exactly what I wanted. Then companies either love or hate working with me because they're used to the surgeon drawing something on a napkin for them. But I brought them this, and I told them that's what I wanted. And I don't know if that made more work or less work for them, but basically this is the most important instrument. It has a way to adjust the size of the component on a millimeter scale, so you're able to do the surgery without any sort of pre-imaging and things like that, which becomes a huge factor as other technology gets more common. Insurance companies are catching on a little bit that the scans that are being done just for pre-planning, which is not necessarily a covered reason to get a scan. So you're seeing more and more patients paying out of pocket, hundreds of dollars to get a CT scan or an MRI before surgery. So this is designed to kind of bring all the available sizes and make little adjustments in surgery to get that custom fit. And between about 8 different size femurs and about 8 different size tibias, a bunch of liners, there's hundreds of combinations of sizes to match every patient. So even though it's kind of science, it starts looking like art a little bit when you start putting it all together. So they made a bunch of them for me. These are the only ones that exist. We have most of them here in this hospital. This might gross some people out. I don't know. It doesn't gross me out so much, but I wanted to put this caution in there nonetheless. So I'm going to show you what a traditional knee replacement looks like. This is why it hurts so much. This is your knee, and then in this position, this would be a typical position for working on the shin bone part of it, but basically the knee is dislocated forward. That's a very uncomfortable position, as you might imagine, but requires a big incision, requires a big release. About 20 years ago, one of my mentors, Dr. Berger at Rush, was one of the pioneers of minimally invasive surgery, and he figured out that if you do the surgery mostly in extension with the leg kind of out straight in a natural position, then you're not having to dissect a bunch of soft tissue and dislocate the knee and things like that. So with special instruments, we can do it through a smaller incision without putting the knee in any extreme position. So I think that contributes a lot to reducing that pain and swelling. So this is more normal for us. When that heals up, this patient's about 4 weeks out. So you have this nice incision just kind of biased a little bit towards the inside on the other knee to stay out of the muscle. This is a patient I saw today. I had to put this in here at the last second because he heard that I was doing this and he wanted me to put his picture in here. So one of the, he had surgery.
12 days.
Yeah, 12 days.
Danny Sadowski.
Yeah.
Yeah, that's family friend.
There we go. HIPAA.
Yeah, that's how I know about you.
Perfect. Thanks, Dan.
Yeah, that's 12 days.
Maybe some on Facebook. This is from Facebook, so it's kind of public. He had his other knee done elsewhere, which was more traditional approach. And maybe this is kind of what you've seen more traditionally, but this is kind of what I've described to patients as a big whack. And then here's him 2 weeks out after more minimally invasive, so he's back on the bike. You'll notice I only have pictures of my male patients doing things that I don't want them to be doing, after surgery. But so that's knees. And then hips, there's a bunch of different ways to do it. We have a lot of great hip surgeons here who offer a lot of different muscle sparing approaches. One that you might have heard of is called direct anterior. That's kind of where this green stripe is in between those muscles. You might have heard of mini posterior. That's farther towards the back. And then the approach that I do is called anterior based muscle sparing, also designed by Dr. Berger at Rush about 20 years ago. To do this, you need the special training to see it because it's a little bit more difficult. But for me, it's a straight shot of the hip. And I didn't write the book about it, but I did write a chapter of it with Dr. Berger, and that was more about the outpatient approach. So having surgery in the morning, going home the same day, which is about 80% of our cases. So with a little bit of planning, here's an X-ray. In clinic, you get this special image taken where I can plan your surgery before. I always plan off the normal side so I can restore the normal biomechanics. So this is planning for a left total hip replacement and then executing that plan in the OR, usually between one or two sizes. So we almost know exactly what we're going to use going in, and then coming out is, about 95% of the cases are within one size. This is a patient lying on their side, so you're looking down at the big bone of their hip is right here, and the incision's right there on the side. So it's about 3 or 4 inches long. That tends to heal up really nice in that position. So recovery is, like I said, what people focus on. That's the most important part. Basically, the first week, I just want you to relax. If you've had surgery with somebody else. You might have been doing therapy the first day after surgery, and we know from large numbers of people that it's actually better if you just take a break for the first week and just let it heal up. If you don't disrupt the anatomy, really all that has to heal is the skin and some of the soft tissue underneath. So nothing special to do that first week. And then week 2, we really let people start easing back into activities like driving and things like that. That's when I want you to start doing some therapy. The funny thing about starting therapy week 2 is that everyone thinks they're so far behind when they get into therapy because, you know, all their friends have been doing it since the day after surgery, but people will notice and they don't believe me until it happens. But at the 3-week mark, they'll be farther ahead than the people that started right after. They'll have less pain and less inflammation because we let the joints heal before we tried getting the motion back. Week 3 and 4, continuing in therapy, and really weeks 4 through 6, most people are doing most things. You're up walking the same day, you're up moving around the same day, but usually you're down for, 3 or 4 weeks kind of before you really feel like yourself again, getting back out, doing more things around the community. For people that are really trying to get back to activities like golf and things like that, I let them start swinging a club at around 6 weeks. Most people are outside riding the bike by that point and things like that. And then really by 3 months, I have people that like to run and ski and water ski, pickleball, whatever, you name it. You really have no restrictions at that point. So you can get back to doing whatever you want to do, whatever makes you feel alive. So that's one part of it. The other part of it is concierge medicine. I really believe in this. I have kids. I've been a patient before, and nothing is more anxiety provoking and frustrating than trying to get a hold of your doctor and not being able to get a hold of them. Here's more. This is more pictures of people doing things I told them not to do. There's golf 4 weeks out, which is probably fine. So customer service really matters. I think Ritz-Carlton, it's probably the best customer service ever. You walk in, they know exactly who you are. They've got your room ready. You call them, somebody answers the phone every single time. Chick-fil-A is also great, maybe not as good. It's not open on Sundays, so that's kind of a disadvantage. But Walmart, you call, maybe you'll wait for a little bit, but then you'll eventually get a person on the phone. Comcast, you're never getting a person on the phone. And then the American healthcare system is down here. It's honestly unbelievable. We have to call other doctors' offices all the time, and my scheduler Marissa's in the back, and she can tell you, she sits on hold all day. And if you get a person, oh my God, it's a miracle. I don't want to do that. That's terrible. I'd rather be up here. That's the goal, is to have this concierge customer service. And what that means, it's really pretty basic. Here's my website. Anyone in the world can click that phone icon right there and call our office. The way that I did that, kind of going into this, knowing that that's what I wanted to provide, was that I built a phone system that's all based online. So instead of calling IBJI, you call my practice directly, and you get one of my team members. So if you've had surgery with us, then we know who you are. You don't have to explain yourself. You call and say it's so-and-so, and we say, oh, hi, we know exactly who you are. And that makes it really nice. It's great for just scheduling things like that, but it's also great if you are concerned or worried about something. The last thing in the world that you want is to get somebody on the phone who has no idea who you are. Instead, after about 4:30, you get me, and I know who you are, and we'll fix it right there. So if you tell everyone you give great customer service, you have to back it up. So here is a patient texted me at 9:30 the other night, and I got back to him in 2 minutes. And I probably would have been asleep 3 minutes after that, but you really have to stick with it. But this, I think, is really the key to having really, really happy patients, is being there for them, not just when things are going great, but if people are worried about stuff, which is at some point in everyone's recovery, you got to be there for them around the clock then. We did 500 cases last year, just about. Every one of those patients has my phone number. Nobody ever calls because we take so much time before surgery educating them and telling them what to expect. So you tell them your leg's going to swell up like crazy. It's going to be bruised from here to here. I expect that. It's going to be sore. When that happens, that's what's supposed to happen. Nobody worries about it. If you don't tell them that, then they'll be very, very anxious and scared about it. So the most important part for me in being able to actually deliver this is the team that I put together. Anna's my nurse. She's wonderful. She worked with one of the surgeons that I worked with at Rush, and I convinced her to come out here with me. Jess is an athletic trainer who has a ton of experience on the sidelines. Marissa, my scheduler, is really my boss. Megan, my PA, and Alyssa, my medical assistant. So hopefully you see one of these smiling faces at some point. When you take great care of people, they want to tell everybody about it. If you take bad care of people, they'll tell even more people. So we've been really, really happy with the response from our patients, and just as passionate as we are about taking care of them, I think people are equally passionate about going out and getting back to doing the things that they love and telling everybody about it. So here's a surgeon's tips for choosing a surgeon. I would really find somebody that you like and that you trust. You can do all the research in the world about all the different latest and greatest things, but the reality is that it takes about 10 years to really understand and appreciate the nuances of what you're getting into, and you're going to be asleep, so you can't do anything in the moment anyway. So find somebody that you trust, and have them do it exactly how they want to do it. The last thing you want is to go to a surgeon and be like, I want it this way, and have yourself be the first time they've ever done that. You just want them to do it the way that they do it. And that's what I would do for sure. Pick somebody with a great team. The surgeons in the OR are operating. You're going to get their team on the phone when you call during the day. So make sure they have a good support system. Make sure they call you back. The last thing you want, like I said, is if you have a problem and you can't get a hold of your care team who knows you and knows your background and knows what makes your case unique. And then this is really important. Who's going to take care of you if you have a complication? And if it's right after surgery, is it going to be your surgeon, or is it going to be somebody else in their group? Maybe your surgeon doesn't do complex things. If your case becomes complex, are they still going to be your doctor, or are they going to send you to somebody else? These are designed to last decades. So you want to pick somebody who's going to be able to take care of you for the lifespan of your implant too. So those are my 4 tips. Thank you guys so much. Hopefully we can do some questions. I would love that. Oh, there's one. Maybe I'll give you the microphone. Oh, great. All right, I'll translate.
I heard about a partial knee replacement.
Yeah.
Can you tell me what that is compared to what you talked about?
Absolutely. I do probably 25% partial knee replacements. Let me back all the way up. It's really simple and it's really quick, and all it is instead of doing the entire knee, I got a lot of slides. Oh, maybe I missed it. There it is. Okay, so partial knee. I probably do the most of them in the group, I bet, if you look at the numbers. So basically, instead of doing the entire knee, you just do that one little side, either just the medial side or just the lateral side or just underneath the kneecap, which is pretty rare. But yeah, so in about 25% of cases, you just have to have that little partial resurfacing.
Do those last as long as the whole?
Yeah, that's a great question.
And why would you do that?
Yeah, why would you do that? So your knee I described like a tricycle. You got 3 wheels. You got a wheel underneath the kneecap, you got a wheel over on this lateral side, and you got a wheel over on the inside of your knee. So if you have a tricycle and you only have one flat tire, it doesn't make sense so much to replace all 3 tires if you can just replace one. The question is always, is that a bridge to a total knee? Meaning, am I doing this and then you got to go back and do a total knee 5 years later? What it seems like is that if you can take care of the arthritis in one part of the knee, that the rest of the knee is protected a little bit. So if you look at 15-year data comparing just a partial knee or a total knee, they do about the same in terms of revising them, and the partials might even do a little bit better. God forbid you're in the 10% in that first 15 years that has a revision. What you can do is you can switch it to a total knee, and it's almost like you started out with a total knee the first time around. If you're in the 10% that needs a revision of the total knee, then that's a much bigger surgery. If I had to have surgery and I could have a partial, I would have one for sure. Great question. Yes.
I've got a microphone. So
Oh, great.
Is this what
Hi.
Hi.
Can you address the anthrax angel system?
Give me more.
The PRP?
Oh, yeah. So there's a lot of different injections to treat arthritis, and most of them have the same goal. When arthritis starts and those bones start rubbing together, there's a bunch of inflammation released into the joint. So the three sort of families of injections, number one would be steroid. In my experience, that works the best. There's some evidence that steroids in high doses and high frequency can degrade the cartilage in your knee a little bit. A lot of times if I'm doing a cortisone injection, you don't have any cartilage anyway, so it's not that much of an issue. But in the lower dose, in the low frequency, meaning not more frequent than about every 3 months, it seems to work pretty well. The second family would be like hyaluronic acid, which people call rooster comb or gel. The evidence is not as good as it is for steroid, but for some people it works like a miracle. You don't know who it is until you try it. I've had not as good results with that, but it's still something that I do a lot. That's designed as more of a lubricant. Hyaluronic acid is a natural compound in your knee that is designed to lubricate the joint. So it tends to work pretty good in mild to moderate arthritis, and it's not work so good if you have really bad arthritis. And then number three would be biologics. This is stem cell, PRP, things like that. These are also designed as an anti-inflammatory. So there's emerging evidence of PRP, which is basically you take out the blood, you spin down the plasma, and then re-inject that, into a joint, in a tendon or something like that. There's good evidence for it in things like tendonitis. If you have like golfers or tennis elbow, it seems to do pretty well for that. It seems to not do as well for arthritis. It's still an option. I've done it before for people that were dead set on it with okay results. It's not covered by insurances. It's about $900 per shot. But people, if that's what they want, sometimes they're willing to pay for it. But emerging evidence. Can't say it's the best thing ever yet. Hopefully that answers your question.
Yeah.
I've
got a microphone.
When would the determination be made about a full or partial replacement?
So, great questions.
That's okay.
When do you know if you're going to need a partial or full? In almost 100% of the cases, it is based on your X-rays and based on your exam. So, if it quacks like a duck and it has feathers and it waddles around, it's probably a duck, right? So, exam, imaging, and then kind of just going based on your symptoms. So, if you only have pain here and the X-rays only have arthritis there and it hurts just right there, then I go into it with the plan being partial versus total. I've never had to convert from a partial to a total going into it thinking, even doing that in about 25% of cases. So usually, in almost all cases, if we think it's going to be a partial, it's going to be a partial. But I'm always ready for anything. Yeah. In the front.
Here, let me bring the microphone so I
Do you ever do both knees at the same time?
Was that the two questions?
No. No, my second question is, when the pain is behind the knee.
Yeah, great question.
Between that. But
So-
if you ever do both.
Yes, the first question is, would you ever do both of these at the same time? A long time ago, people did that very frequently. We know now from doing that a lot that your outcome, if you do both of them at the same time, is not as good if you space them out just a little bit. 3 months apart. Sometimes it's close to 6 months apart. I've done them, I think, like 3 weeks apart was the closest I've ever done them. But it seems like your body needs almost all of its reserve to really heal that knee up as much as possible. When you have them both done at the same time, it seems like the healing process just takes, 50% longer for each one. The other problem is that when you have both of them done at the same time, you tend to sit a lot, so that you have a lot of trouble getting both of those knees all the way straight. When you do one at a time, I think you're up more, and you're up with that knee straight more. So yeah, I've gotten away from doing that. So 2 at the same time. So usually we do them spaced out. So, and then number 2, pain in the back of the knee. Arthritis, as the joint becomes a more rough surface instead of a smooth surface, your body's response to that is to make a ton of fluid. Just try to lubricate the joint, try to make the joint swell up so you don't move it as much so it doesn't hurt as much. There's really no place for that fluid to go other than backwards when you bend your knee. So almost everyone has what's called a Baker's cyst, which is this collection of fluid in the back of your knee, usually on the inner part of your knee, that when you try to bend your knee backwards, it feels like it's going to explode. Sometimes it does rupture. I've seen that before where people, all of a sudden their calf's swelling out, they're in a ton of pain. They'll go to the ER and they'll think it's a blood clot and they'll do an ultrasound, there's no blood clot. And they're like, well, I don't know, but your leg's definitely swollen. That's usually what it is. At the time of either a partial or a total, the reason that Baker's cyst happens is that there's a one-way valve in that spot in your knee between 2 muscles that kind of come together a little bit like this. The fluid gets out, but it can't get back in. So at the time of surgery, I open up the mouth of that pouch so that you might still notice that there's a little bit of fullness right after surgery, but as the swelling goes down, the cyst goes away and it doesn't come back. Yeah. Yes.
Do you customize physical therapy per patient's ability, maybe age considerations?
Yeah, for sure. For sure. Most of our patients do what's called a pre-op physical therapy visit, where number one, I didn't mention this in the talk, but we give you about a 35-page book. You can actually download it off our website in the patient download section, but we give you a paper copy of that book, and one of the sections is like pre-op physical therapy. People are able to tailor that a little bit to themselves, but you also meet with a therapist before surgery. And they do like a head-to-toe evaluation of you and kind of see where you are now, see what you need to focus on in your recovery, and then they kind of take the lead in terms of individualizing that. We give them specific instructions, but kind of within some flexibility where they can work with you one-on-one. We've got great therapists. A lot of people come here to the Shirley Ryan, and a lot of people go to, we also have an outpatient place on the 7th here too. That's awesome. Yeah. Yes.
The swelling I've had has been above my kneecap and off to the side.
Yeah.
And it's been chronic as long as I've been having knee pain.
Yeah.
Can you talk about that? And by the way, it's worse on the knee. He had x-ray both knees, and it's worse on the knee that the x-ray looked better on.
Yeah, isn't that weird? Yeah, usually early arthritis tends to make more fluid. It does what we call, it kind of burns itself out after a while, where when you have terrible arthritis, it's almost like the knee's given up, it doesn't make so much fluid. But that early arthritis that might look a little better on the x-rays usually makes more fluid. The knee really has only one pouch around it, so that if you can imagine, there's like a soft tissue, you might not be able to see my mouse, but the envelope around the knee actually goes all the way up into the thigh, almost all the way to the top of that x-ray. So some people have pain that goes, almost halfway up the thigh, because that's where the lining of your knee goes up to. Yeah, that's very common. That'll be $500. Hunter the Duke in the front row.
Hey, Doc.
Hi.
Question for you about, so we all kind of know the term better late than never.
Sure.
Thank you. So we all kind of know the term better late than never. But how late is too late with joint replacement?
Mm-hmm.
And there's many reasons why somebody may not want to come and get their knee replaced. They're scared of the pain. They're not sure who's going to take care of them when they get home. Maybe there's just some narrow fears overall about surgery. Is it better for them to come in early and get assessed and kind of get that ball rolling at an earlier stage? Or is the longer they wait, does it make harder on you to do the surgery? And how does that affect their recovery, rather than if they came in and got it done earlier?
Great question. I think getting evaluated earlier is always great, because I think there's, I don't want people to suffer needlessly. Not everyone's going to need a knee replacement the first time you see people, and I do a lot of non-operative care for arthritis. I also don't believe in prophylactic joint replacement, which is replacing the joint early just so it doesn't get bad in the future. Oh my gosh, I don't want you to get worse arthritis, so we better rip out your knee now. What I believe in is trying everything. That's what I would do for sure. You want to do things that are low risk first, and then if you have to, do surgery, which is relatively high risk compared to something easy like a pill or a shot or something like that. So everyone that I offer surgery to has exhausted everything, and you know, you have to set aside 4 to 6 weeks of your life to get this done and recover and dedicate the time to it to have a great outcome. So, you know, it's got to be something that interrupts your life. So there's nothing, it's never too late. I do a lot of much older people. The oldest person I've done is 99. Age to me is just a number. This 99-year-old was super active and they were totally healthy and they had like a really bad hip. And I was like, yeah, I mean, sure, I'll replace your hip, and they did great. And now they're out mowing the yard, you know, acting like they're 45. So, yeah, I don't think age is a cutoff. And then another thing that I'll loop into the conversation, I get asked this a lot, is about cutoffs. People make up a lot of crazy things like BMI cutoff or other numbers cutoffs. I don't believe so much in strict cutoffs because I think markers don't always apply to everybody. So I don't have formal cutoffs for, you know, BMI and things like that. We try to go based on making people as healthy as possible. It's been a recent trend recently for people to take medications like Wegovy and Ozempic and things like that that are really designed to suppress your appetite. Those make you skinnier for sure. I don't know if they make you healthier. So what we focus on with people is really trying to optimize your nutrition, trying to get as many nutrients in your body as possible so that your immune system is built up. And what we see is that if people focus on their diet and their exercise and things like that and lose weight healthier, I think you are lighter, but I think you're a healthier person too. So that'd be another thing about optimizing yourself if you're going to go at this alone and try to make your knee feel better on your own. Yes?
You said that knee replacements generally last 10 to 20 years. How much do you have to go through, like if you do need to do it a second time?
Yeah, that's a great question. So if you look all the way on this picture to the right, so this knee replacement has the metal parts are glued into the bone. This plastic liner here is what we call modular, meaning that liner clips in and clips out. So if you were able to go run marathons in this thing and wear it out fast, what you can do is you can go and take out the plastic liner, put in a new plastic liner. And I do that pretty frequently. I just did that on a 96-year-old who is doing great. But basically, you know, the knee, when it starts to wear out the liner, starts to feel unstable again. It doesn't work as well. So we go in and put in a fresh plastic. What's cool is that the technologies usually they've advanced the technology a little bit. So now you get like an updated type of plastic too. So, but that would be the solution if you're able to actually wear it out. Yeah.
Yeah, I'm on the gel steroids. How long do you have to be off that before you can go in for surgery?
Great question. Large numbers of patients that have had surgery, it looks like about 3 months is the safe time to wait. Every time you put a needle from the outside world into the inside of your knee, even though we clean it off as much as we can, we use a couple different things to clean it, there's probably a couple little bacteria that go into your knee. Your knee has its own immune system, basically. So there's cells in your knee that are waiting to gobble up those little bacteria. And in a normal knee, that's no big deal. They just gobble it up and, you know, it's gone like it never happened. In a knee that has a bunch of metal in it, the bacteria can stick on that metal and create what's called a biofilm, which is their defense to make it so that no antibiotics can penetrate their little kind of cluster. And then it's a real problem. So we try to wait about 3 months. Usually it's about 10 or 12 weeks.
Last shot, we'll wait 3 months.
Exactly. Mm-hmm. Yep, exactly. Yeah. Oh, I saw 2 go up at the same time. Ladies first.
So by the picture, the metal that you put in the plastic, that just goes into the bone, that's how it's held together?
Exactly. So the metal goes into the bone a little bit, and from this picture, it looks like a big piece. It's really a pretty thin piece. The way that that gets fixed to the bone is it has a special bone cement for most patients where you apply some, it's more like a grout. You apply it to the bone, you apply it to the component, it sets up. It's actually like plexiglass, it's polymethyl methacrylate. So once that's hard, which happens in about 10 minutes, then that bond is as solid as it's ever going to be. That allows people to get up and walk on it right after surgery. The plastic part is designed to sort of snap into the middle part. So those two pieces come apart.
That can be replaced, that's the part you said.
The plastic part. Mm-hmm.
We can take a couple more questions if anyone has.
Yeah, in the front.
You mentioned that there's different types of surgery, inside, lateral, and so on.
Yeah.
Do they all have about the same recovery time, or is the one that you recommend that you do probably have a better recovery time? What's the negatives to it?
Sure, that's a great question. So do all hip approaches have the same recovery times? It's something that orthopedic surgeons debate all the time because everyone wants to tell you that their approach is better. We know that at about the year mark, all approaches pretty much even out to be about the same. So your long-term outlook with hip replacement is great. They do awesome. They're some of the happiest patients in all of medicine. There is evidence that in the first 6 weeks, if you use an approach that goes in between the muscles instead of cutting the muscles, that the recovery is a little bit quicker and you have a little bit less pain. The reason that I do the approach that I do, one is that I was trained special for it, so it's not something that you want to jump into once you're already in practice if you didn't do a fellowship or do some sort of training. The reason I do it is because I think it's the most muscle sparing, and it also allows me to do pretty much every type of anatomy and every type of patient that comes through the door. So for some approaches, you have to have a cutoff because it becomes very difficult to do it. Once you have either sort of overhanging skin in that area or too much soft tissue or the arthritis is too bad. The approach that I do, I'm able to do on basically every hip that comes through the door. That's how I do it. So it's utilitarian, but it also is very muscle sparing as a first cover. Yeah. Yes, sir.
Where is the cutoff between the injection, the lesser invasive injections versus the total knee replacement?
In terms of symptoms, or how do you know when it's time to do one versus the other?
Exactly.
Yeah, so if the injections are working for 3 months, then it's great, and you come in every 3 months, we'll do that forever or until I retire. There's no limit to the number of injections you can get. So if they're working great, and I have patients that come in every 3 months, they're like, that was awesome, it wore off yesterday. And then I give them an injection, and I'll see them in 3 months, and they're doing everything they want to do. When it's time to have surgery is when the injection wears off after a week or two or a month, and then you suffer for 2 months, and it starts to impact the things that you want to do. So if you're doing everything you want to do, then I'm not going to push through a big operation and the risk of an operation. We're going to stick to the low risk things, but if it's affecting you, then it's time to take the jump.
And that's all in the initial stages as to how much damage is there.
Yeah, exactly. It's pretty rare for me to meet someone for the first time and just like sign them straight up for surgery unless they're coming to me for a second opinion where somebody else has been doing injections and they know they need surgery and I operated on one of their buddies and now they want to come to me just for a second opinion. Those are the people that end up getting surgery right after I meet them. But I'd say most of my patients I know for a while, and we go through everything together. And by that time, I know you and you know me, and it makes the actual surgery part even easier. Yes, sir.
How does that,
I'm sorry.
in terms of traveling, did you say it was plastic, so do you you don't need any paperwork when you're going to TSA?
So there are metal parts. Now that they use a lot of whole body scanners in the airport, it used to be that they just had a metal detector and it's like there's something metal in your body, but we don't know where it is. So you'd have like a laminated card that said, I had a joint replacement. You could show them that. Now that they have the whole body scanners, you just tell them I had a joint replacement, they'll put you through the scanner and they're like, oh yeah. Like, is that partial or total? So now you don't have cards, so you just let them know. But depending on the sensitivity, if you have more than 2 joints replaced, usually you'll set off like a normal metal detector. but it depends how it's tuned. If you've had all 4 joints replaced and you walk through one and it doesn't go off, I would turn around and go back out. Yes, sir.
You talked about complications after knee replacement. Could you elaborate a little bit more on what that might be?
For sure. Yeah, the things that keep me up at night and the things that, the reasons knees get revised in the US, number one is infection. That's about a 1% risk. We do everything we can to minimize that. You get antibiotics before, you get antibiotics during. I leave some antibiotics in there. There's antibiotics in the cement. And then for really high-risk people, we'll give them oral antibiotics after. That keeps it to about 1%. Other reasons knee replacements get revised, either they're too loose, meaning your ligaments stretched out a little bit and you have feelings of instability, or they're too tight where you don't get your motion back. I do a lot of redo joint replacements that come from other places, and I do a fair amount of that kind of work. Either adding more plastic to that plastic liner, or redoing in some other way to help get them in motion. Yesterday I did like a 3-hour revision of a lady who had surgery also, and could only move her knee about 10 degrees. So that's much more extensive. You have to redo the whole thing. And then the third and most common reason that things get revised are that bone cement interface becomes disconnected somehow, debonds from the bone, but that's pretty rare. That's something that you usually won't see after about 20 years. There's other styles of components that are designed to grow into the bone. In a certain percent of cases, those don't even grow so well. That would be another cause for earlier revision, but I'm cementing just about all the needs. It takes a little bit longer, but I think it helps people recover a little bit faster. Yes.
Hi, Dr.
Nice to see you.
I just had hip surgery August 13th, and I'm doing real well. And everything that this man is telling me is exactly what happens.
And I didn't even have to pay you to say that.
No.
But I will.
I didn't have surgery here, but we went to LaGrange, and I never seen such a smooth process getting you prepared for surgery. And I was all worried, everything, and it just went one.
That's right. We got it all figured out.
Yeah.
Well, thank you.
And the food was delicious.
Well, we love Silver's cafeteria.
I didn't say, I say I also, because I live by myself, were able to have tea at home.
Oh, yeah. That's a good
And
point.
so that was really a plus.
For sure.
But like he says, everything that he is saying is exactly what goes on, and his staff is excellent.
If they were on fire, then so we have a sense.
And when we talk about, he's very much in contact with his patients. I'll text something, some small little thing, and he's right there responding back and forth. And you need this. You really need to have that communication with your doctor, because we worry about some of the littlest things, but yet we need to talk to somebody about it. So,
Well, thank you.
again, I thank you very much.
My pleasure. Thanks for being here. That is one thing that you brought up that I didn't mention, but I told you we love education. You get the 30-page book. We also have a service that I help set up that sends you a little snippet, a little text message just about every day, starting 2 weeks before and 6 weeks after. When I tell people about that, they're like, no, like that is going to annoy me so much. And then people after are like, oh my God, like I was having this pain, I'm not sure if it was normal, and then right in that moment I got this text message that's like, you might be having some thigh pain right now, and that's totally normal. I felt so much better. So that will almost read your mind. But yeah, we had most of our patients do that, and I really, really like it. One of my friends from Rush started that company, and we've used it with great success. Yes, ma'am.
Side effects of the steroid shots, and how long does it take to get an appointment with you?
Great question. 2 questions again, I like that. Side effects of the steroids. For people that don't have diabetes, side effects that I've seen are sometimes you feel a little bit restless, sometimes you don't sleep so good the night after. I think that's, almost all the steroid stays in the knee. But I think maybe a little tiny that gets into your body, and that's kind of what you feel. If you have diabetes, you will see your blood sugar go up a lot for about 3 days. There's no real bad long-term effects of that, but you'll notice it, and it freaks people out. And we haven't seen any actual complications from that, but your numbers will definitely be high. That doesn't happen with gel. So a lot of times in our diabetic patients, we will train towards using more gel. And then to get a hold of me is relatively easy. We see a lot of patients. I see about anywhere from about 120 to 200 patients a week. And then we try to do about 10 or 12 or 14 cases a week. So I'm in clinic a lot, so it's pretty easy to get an appointment. But I would say it takes a week or two to get in. Yeah, that should be about right. Depends on your flexibility, and the same goes for surgery. I operate at 3 places here, the LaGrange Joint Center and then Plainfield Surgery Center. So my time is split equally between those places. So it's the same for surgery. If you gotta have surgery at Silver, which I totally understand, it might be a little bit longer wait. If you're open to going wherever I'm gonna be that day, then it's usually a little bit faster. But I like to book out about 6 or 8 weeks. I think Marissa will kill me if I tell you any faster than that, but that's usually enough time for you to see your primary doctor, to see your specialist doctors. But that's the funny thing. You call me and I can see you tomorrow. You call your primary doctor and you're like, hey, I need a pre-op appointment. They're like, no. It's like, we'll see you in 6 months. So it's usually harder to get into them than it is with me, just because we see a lot of people. Yes, sir.
We keep hearing about cartilage this, cartilage that.
Mm-hmm.
Is there a way to regrow the cartilage or regenerate it, or maybe replace it with a cushioning material?
I hope not, or I'll be out of business. But so people have been trying that forever. That was the first idea 75 years ago. There's been a million things. It doesn't seem like anything works as well as this. It's some of the most successful surgery that we do in all of medicine. But maybe at some point there will be a way to regrow cartilage, but it's a very harsh environment. Every time you're going up and down the stairs, you're putting 4 times your body weight on your knee. So to engineer something that will stick fast enough for you to not be bedbound for a couple months while it grows in, I think will be very, very difficult. But we're always working on it. Is there some role for stem cells and things like that? I hope so. Maybe down the road. Right now, it's still one of those areas of medicine that's really hard to study because it's not standardized and it's not common. It's also very expensive. Stem cells can be anywhere from $10,000 to $50,000, depending on the formulation and things like that. But so far, sometimes it's hard to try to improve it so much when we've got resurfacing the joint so much down to a science that you can have surgery and walk out the same day and sleep in your own bed and then be back to doing everything you want to do in 4 to 6 weeks. I think it'll have to be something really revolutionary to be better than that. Cool. Well, thank you guys so much. I really, really, really appreciate it. If I can do anything for the kids,